All right, everyone. Good evening and welcome to tonight's edition of the AMSSM National Fellows online lecture series. Today we have a talk about public health and athletes. I'll be your moderator this evening. My name is Julie Creech-Organ, and our esteemed guest is Shefali Christopher. She is a physical therapist, has her doctorate and as well as her certification in athletic training, and she is going to really wow us with some new education tonight. But before we get started, I just wanted to go over the basics. So the goals of this evening's presentation is to serve as an adjunct to your program's educational components, as well as give you time to learn from our esteemed AMSSM members, as well as our invited guests and speakers, and then also help assist you with your CAQ preparation. As always, we do have some ground rules for tonight's presentation. So we ask that you mute your computer's microphone and turn off your video just while the presentation is occurring. There will be the chat function open the entire time during the presentation. So we ask that you submit any questions that you might have in the chat. I'll be monitoring those so we can go over them at the end. And that's where we'll have some Q&A with Dr. Christopher herself. And then at the end of the lecture, we do ask that you submit any evaluation that you have of tonight's presentation so we can make improvements. One of the new things that we're doing is trying to get the topics you want and the speakers that you think are meaningful. So you'll see that if you go to the AMSSM website, go to education and then the fellow online lecture series, you can complete a topic request form here. Or if you are tech savvy and want to use your iPhone now, you can go ahead, I should say your camera phone now, and go ahead and scan this QR code. And that will get you straight to that webpage that we just looked at and allow you to submit any speaker or topic suggestions. So it is now my pleasure to introduce tonight's speaker, Dr. Christopher. She serves as the Director of Admissions and is a faculty member at the Tufts DPT Seattle program. She is a clinical specialist in sports physical therapy through the American Board of Physical Therapy Specialties. She's an active member of the APTA, American Academy of Sports Physical Therapy, or AASPT, and has served in leadership roles for the Running and Female Athlete Special Interest Group. Dr. Christopher has numerous publications and presentations related to research on returning to sport after childbirth. In 2020, she was awarded the Excellence in Teaching Award by the AASPT and received the Academy of Pelvic Health Research Grant in 2023. As part of her service, she supports USA Para-Triathlon at numerous international races and was a medical liaison to the team in the Tokyo 2020 Paralympic Games. So without further ado, I will turn it over to Dr. Christopher now.
Thank you so much for having me today. I'm going to go ahead and share my slides. All right, so hopefully you can see the slides nice and big, and we're going to start. Well, thank you everybody for coming today. And I'm really excited. Thank you for that awesome introduction. I'm really excited to talk about pelvic health in athletes. I've worked with so many primary care sports medicine fellows during my path of being a clinician at Duke Sports Medicine, and through some just absolutely wonderful physicians. So I'm really excited to present to you today. So thank you for having me. Just a couple of things as we start. Oh, there we go. Disclosures. I wish I had some financial disclosures, but I don't. So nothing financial to disclose, but I get really fired up when we talk about the female athlete, the lack of research, and just in general, some things out there that I wish was more common. So lots of hand movements, a lot of gestures. Please don't get distracted by it. And hopefully you'll just get excited about the topic at hand. I also have children running around this evening, so hopefully we can get through this presentation without too many Zoom bombs, but maybe Andy can delete them later. All right, so we're also going to use some gender-affirming language today. I will refer to female athlete a lot, but not all people dealing with impairments and dysfunction topics related to this presentation identify as females. So as you're thinking about this on the patient in front of you, please keep that in mind. The biggest objective today is really thinking, as that patient comes in injury and pain is so multifactorial that when are we forgetting about the pelvic floor or pelvic floor dysfunction that could be part of the puzzle in front of us? And so how do we screen for it? How should every athlete be asked the questions about pelvic floor dysfunction? And then I'll talk a little bit about referral sources and what your options are if you don't feel comfortable doing much more than asking the questions. So really excited about really focusing on that today. So pelvic floor dysfunction in general is three big things. It can be pelvic organ prolapse, can be pain, and it could be some incontinence. So we're going to break that down. So pelvic organ prolapse can happen up to 50% of women. And as you can see, they could be bad prolapse, they could be vaginal prolapse. So there are different types of prolapse. The biggest thing is that your athlete will complain of heaviness, pressure, bulging in the pelvic area. And that may give us some signs and symptoms that this athlete may be dealing with some prolapse. And why it's related to athletics is usually seen with high impact forces. And for some reason, there's a descending or drooping of the organs or loosening of ligaments. And I do a lot of work in the postpartum pregnant world. And so we talk a lot about prolapse in that population and making sure that they don't have prolapse as they're getting back to sport. If we talk about pelvic pain, we see that in up to 26% of women and up to 16% of men. And this is kind of like the catch-all, like, knee pain. So you can have the lower back, the hips, the groin, the tailbone, sacroiliac joints. So just a catch-all term. And it could be discomfort with basic daily activities, or it can also contribute to constipation, abdominal discomfort, difficulty exercising. It could be related to bowel and bladder dysfunction, pain with intercourse. So all of those things. And so that's pelvic pain. And then when we come to incontinence can be leakage, but even a few drops. So when I'm asking patients about urine or fecal or gas incontinence, I say, do you leak even a couple of drops of urine, feces, or gas? And that's a good opening question to ask about incontinence, because usually if they're just having a few drops, people don't think about it as incontinence, but that is incontinence. And fecal incontinence is a little bit less common. So 8.1% in males, 8.9% in females, and urinary incontinence is much higher. But because lots of people don't like to talk about it, it's very highly, it goes undiagnosed. And so the more we can ask, the more we can kind of put our finger on if it is part of the impairment puzzle or this dysfunction puzzle in front of us. There are several risk factors for incontinence, like age, parity, hereditary factors, delivery mode. They already have prolapse, they're postmenopausal, ethnicity, diabetes, obesity, sedentary behavior, UTIs. But I love this diagram that shows, just like with general aging, how the percentage of urinary incontinence increased in these two Swedish population of rural and urban. But it just shows that it is part of aging, but it shouldn't be normal, and we can do something about incontinence, especially. There are also different types of urinary incontinence. So there can be stress incontinence, and that's the one that we'll talk about the most when we talk about athletics, because it's the total the stress in the abdominal cavity. But you could have urge incontinence, which is when someone is about to open the door and they suddenly leak because they have this urgency to go to the bathroom. They open the door to the bathroom. Sorry, I should have said that. Not just any door. And then there are different types of incontinence, like overflow and total incontinence as well. Just a little bit more about that. So if you're looking at stress incontinence, it's due to that increased intra-abdominal pressure under stress. And that's really what we talk mostly in athletics is, are they holding their breath? Is that just too much abdominal pressure, especially as they're running, doing those high impact sports compared to other things? And some of the others may involve, a blockage of the ureter, impaired nervous system, or just involuntary contraction of the bladder muscles. So we'll talk mostly about stress incontinence today. I did want to put this slide up. So, pelvic health used to be called women's health, but it does happen in men as well. So if you're having a male athlete and they're having pelvic issues, and we'll talk about some of those, it may be good to even ask the question just in case there is some pelvic floor involvement or there's some pelvic floor dysfunction happening in this athlete. So when we talk about athletes, this is really underreported, as I mentioned before, but about 46% of endurance athletes report incontinence, up to 80% of female athletes, 80% of recreational runners, and in recent studies looking at postpartum runners, at 2 years, 19.1% and 27.7%, some of the incidents that has been reported. I think it's important to say they did send a survey after the London 2012 Olympic and Paralympic Games to the athletes, and only 2% responded. And of those, 50% experienced urinary incontinence, and 5 had discussed this with their medical provider. So it could be that, they just don't feel that it's abnormal. Some groups, like especially some of the mom groups that I'm a part of, talk about, oh, are we doing, tuck jumps? Are they called tinkle tucks? They make jokes about it because they think it's common after having a baby and things like that. But it's common, but it shouldn't be common. We can do something about it. And so important to ask the question. And then when looking at even younger athletes, about 12 million adolescents, so 34.9% reported incontinence. 17% developed those in junior high and 40% in high school. So again, we're seeing it even in the younger, really active population. And the more we ask, the more we will know about it, especially as if we're trying to deal with all the symptoms they're having related to the injury. I wanted to show specifically, because I work in running, some of the running trends. And, as sports medicine providers, we see a lot of runners in different capacities. But this was the 2020 US Trends Running Report, and they showed the age distribution. Lots of female runners. So in some categories, even more female runners than males. So we're going to see these people in our clinics as they, get injured and different things like that. And so it's going to be important to keep this in mind as a differential diagnosis as we're looking at low back, pelvic, lower extremity injuries that could have a component of pelvic floor dysfunction. So high impact sports is one of the reasons they could have incontinence. So what are some different types of incontinence in runners? So we talked about, in the general population, but in runners, you can have stress urinary incontinence, you can have urge incontinence, and you can have a mixed where they have both stress and urge incontinence. And one of the big reasons we talk about that stress incontinence is that increased intra-abdominal pressure. And so as there's increased abdominal pressure, the pelvic floor contracts and exerts a pull, and it pulls that anterior vaginal wall towards the pubic symphysis, leading to an occlusion of the urethra and preventing urine leakage. So when there's something, when it just cannot work like it should, then we can have some leakage right there. So when we talk about the anatomy, this is a good picture of the core. You have the multifidus in the back, the transverse abdominis in the front, the diaphragm on the top, and then the muscles of the pelvic floor. And really, if we look at those muscles of the pelvic floor, it's just a thin layer that's doing so much work. It's supporting so many organs, and it's doing just an amazing job. So we need to help it be healthy and stable and all of that. And just a quick reminder of the anatomy, there are 3 layers of the pelvic floor. And if we're looking from, the top is the anterior, bottom is posterior. So we're looking up at the pelvic floor. You have the bulbocavernosus muscles, you have the ischiacavernosus, and then you have the external anal sphincter. And this layer 2 is this sphincter urethrovaginalis, the compressor urethra, and the external urethral sphincter. And here, this layer compresses and relaxes sphincter during micturition, passing urine. and may close the vagina. And then layer 3, here's where you have your levator ani muscle, your puborectalis, your pubococcygeus, iliococcygeus, and all of these, they reinforce the sphincters, pull the coccyx towards the pubic bone, and provide stability and endurance off the pelvic floor. I wanted to show this picture again, that, both the male and female pelvic floor look very similar. And so as we're talking about pelvic health dysfunction, we want to make sure we include all athletes if they're having symptoms. So this is actually a really nice summary of the muscles of the pelvic floor. And I put this in mostly so that you have this reference. Grania Donnelly and Izzy Moore just put this report out, and it's Sports Medicine and the Pelvic Floor. In fact, they actually won an ACSM award this year for this report, but it's a really nice review. So if you're working with other residents, if you're working with other fellows or even residents actually, and you want them to know more about this, it's a really easy, nice review read and kind of a summary of this presentation in a nutshell, but a good resource to have, and kind of reviews some of the innervations and functions of the different muscles if you want to go into detail of that. I love this picture, and I really wanted to show you. So here we're looking at the sagittal plane, and we're looking at, the hemipelvis. But here, as you can see, we have our lower leg muscles, so your adductors, your hamstrings, all of that. But they're all connecting right here on that pubic bone where the pelvic floor muscles are connecting. So if you're thinking of, compensations or tightness, different things like that, they're so close in nature that we would have to, they may be involved as well when there's an injury. And so especially injuries that are coming in, someone who's female athlete, someone who's been through perinatal lifespan stage, we definitely need to ask about pelvic health symptoms because of the pelvic floor muscles being so closely originating and inserting to the muscles of the lower leg and hips. Here's another view to show you of the different muscles and how they're very closely connected. But you have the QL up here, the iliacus, the psoas, you have the piriformis, and in the Donnelly paper, they even called the piriformis one of the pelvic floor muscles. You have your obturator internus here, of course, your glute med, and then you have your abdominals and your adductors. So everything is very closely related and really worth our time and energy to make sure that as the injury is multifactorial, that there's no pelvic floor dysfunction associated with that injury or maybe even contributing to that injury. This is the groin pain in athletes paper from BJSM, the Doha agreement. But I wanted to also point out here, as you're sorting through adductor related pain, psoas related groin pain, inguinal, all of this, it's going to be important to ask the questions about pelvic health, the athlete's pelvic health, because that definitely could play a part as well. To give you, if you didn't believe me, this study by Kari Bo et al., she took 6 PT students who, I don't know how they agreed to needle EMG. And as you can see here, when the EMG, when they did a pelvic floor muscle contraction, and then this is pelvic floor muscles when they did the Valsalva or bearing down or coughing. But then here is the pelvic floor when they did an adductor test, an adductor exercise, a glute exercise, some pelvic tilts, and sit-ups. So if you didn't believe me because the anatomical locations, there is this coactivity pattern that's happening with the outer pelvic floor muscles and the pelvic floor muscles. And so it's going to be important for us to consider it in our differential diagnosis as we're sorting through the components of the injury. So how it all works together, the detrusor muscles relax and the pelvic floor muscle contracts, and through the different processes that happens to be able to let out the stream of urine. And if we're thinking about muscle fibers, the pelvic floor muscle has 70% endurance and 30% fast twitch. So those are going to be the different ways of, as we think to strengthen the muscles that we would incorporate exercises. the different terminology when it comes to pelvic floor dysfunction is it could be non-contracting, non-relaxing, or a mix of non-contracting and non-relaxing. So really an underactive pelvic floor is probably how, the layperson thinks of the pelvic floor, that it's just a droopy hammock and it's just muscle weakness. That's an underactivity that's leading to the inability for it to do its job. So you can have urinary incontinence, fecal incontinence, and even prolapse through this. But a lot of times when I'm working with high level athletes, what I'm actually seeing is it's one of those like muscles that's just so tight and it's not relaxing. So the biggest pet peeve I have, see, my hands are going crazy because I told you I get really fired up, is one of my pet peeves is, that, if you look on the media, it's always like, do your Kegels. But if someone's muscle's really tight, if they kept doing Kegels, it's actually going to make the problem worse, not better. And so really the athlete needs to go see a pelvic health provider so they can do an internal exam and really get an idea of, is this an overactive muscle or is this an underactive muscle? And if you think, I use my fist as an analogy. If you're clenching your fist all day, at the end of the day, it's going to get so tired that it's going to kind of let go. And so that's kind of what your pelvic floor is doing. It's like really tightening up and, trying to do its job. And then it just fatigues out and may have symptoms because of that. So as we think about different dysfunctions, it could be overactive or underactive. And those are the things that the pelvic health provider would really be able to do it in evaluation and take a look. I like to put this, I wanted to put this slide in again from the Donnelly article about other red flag symptoms of pelvic health dysfunction. And so just keeping an eye on, is it something else, some serious pathology like a pelvic mass or things like that, just some symptoms like persistent vaginal bleeding, which, common sense, we would all, send somewhere, but maybe we're not asking the questions enough to identify if something is going on. And that's really what we need to be doing, making sure we're consistently asking about, menstruation and pelvic health in general. And then thinking about, modifiable and non-modifiable risk factors for pelvic dysfunction. So you have, your general factors and pretty much similar to other things, higher body mass index, a smoker, sedentary behavior, here you'd have constipation, maybe diabetes. But as you all are going to be sports medicine physicians, it's the sports the modifiable sports factors are that impact sport, strenuous exercise, high intensity activities, and relative energy deficiency syndrome. And that's one of the things I'm gonna talk through these in a minute. But some non-modifiable factors, you can see some general ones like age and gynecological surgery or cancer, things like that. But pregnancy and labor. And because that's my area of expertise, I'm really excited to bring that in and talk to you a little bit about that as well. So let's talk more about sports and the pelvic floor. And so here, when we talk about impact sports, why this is of any consequence is this is a diagram of running forces. And so this is vertical ground reaction force, anterior posterior reaction force, and medial lateral forces. And those are the three forces when someone's running outside that are acting on the body. This is that initial contact, whether it's rear foot or forefoot or whatever, this is that initial. And then there's this increase in contact. And that can be the forces can be up to 2.5 times the body weight. So the body has to, brace and respond to those high forces. And so that is one of the considerations when we're thinking about the pelvic floor and it's bracing and it's doing its job. It's like absorbing the ground reaction forces as well. There is a theory of faulty mechanics. So as you think of the diaphragm and the pelvic floor kind of moving together, one of the theories is it's a piston and they have to work together, not work against each other. So as you breathe out and the diaphragm goes up, that's when the pelvic floor should contract. And then as you breathe out, and the pelvic floor should relax. But as you saw with that overactive, maybe someone's having some urinary incontinence. And so they're just tightening the whole time when they're running. And as a result, it's not working like a piston as it should. And so thinking about this dynamic core will be one of the things that we could look at and, to just teach some breathing and teach some normal mechanics as they're having these symptoms. So that breath holding, or them like, like one of the common things we used to do a while ago is, okay, tighten your core and run, and no one can tighten that core and run the whole time. And so, really thinking of like having normal mechanics versus like trying to do something abnormally in the pelvic floor not doing its job. So the other factor we talked about was another modifiable factor is just strenuous activity and fatigue, and really haven't seen much research supporting that. And so if we see this study looked at strenuous a group that did strenuous exercise and a group that did non-strenuous exercise, and really in both cases, both vaginal resting pressure and the pelvic floor strength went down post exercise, but really between the groups doing the exercise, there was no difference. So really keeping an eye on this, but we're still trying to find some good literature that supports it. And one of the big things is there's not really good gold standard measures or easy ways to do pelvic floor research. And so we're going, there's going to be something we looked at. And just so that the strenuous group did CrossFit and the non-strenuous group did some self-paced walking, if you're trying to think of like what type of exercise. Okay, and another big modifiable factor that we read about was relative energy deficiency syndrome. And I think y'all probably know a lot about this, and it's in the easiest sense is energy in is not equal to energy out. And the body starts to break down and not keep up with the regular functioning. And so asking the question about menstruation and regular periods is a good one of the screens for relative energy deficiency syndrome, as it might tell us about some energy intake abnormalities here. But in this study about intrinsic and extrinsic factors contributing to running related injuries in adolescent runners, they found that the intention to lose weight to improve athletic performance increased the odds of getting injured by 4.58%. So I think that this is a really important one too to think about as the athletes in front of us. Do they have good dietary intake, or are they in this pattern of relative energy deficiency syndrome, and is that contributing to a bunch of different systems shutting down and injury? So something to think about. The non-modifiable factors that they talked about, one was pregnancy, especially if they're greater than 30 years old when they're having the pregnancy, or if they've had multiple children, and labor. And so if there's any injuries during labor, or if they labored more than 1 hour during second stage of labor, those were the risk factors for pelvic floor dysfunction. So why I bring this up is, yes, so they've had multiple children, but it's a muscle at the end of the day. And so what we can do is referring them to a pelvic health provider who can kind of work through if they've had a labor injury, if they have that overactive pelvic floor, if they have underactive floor, giving them the right exercises so that the incontinence is less and they can have more success going back to sport, and or if they're having pain or prolapse, that we can try to do something about it at this stage, or then refer them to a urogyne for further treatments and things like that. I also wanted to share from that same running report kind of age and gender distribution, since we are now talking about the perinatal stage. And so if you look at the 5, 10K, even the marathon, as we go into the 25 to 44 age group, that's when a majority of the runners are participating in these events. So it is likely that we're going to see, the pregnant, the postpartum runners coming in as they're making up a large percentage of the runners out there. And in 2009, 98% of births were happening in the 30 to 34 age range. So really this fits kind of this diagram here. So as we move into talking about the perinatal stage, one of the things that we know about postpartum runners is that about 80% of the postpartum runners report running related pain. And really thinking about like what component of that is the reason for this pain. Thinking about load that the body has having to take on with the ground reaction forces or whatever the sport might be, and also the capacity of the body to be able to handle that. So is it that there's something that's not ready for the load? Are they strong enough? All of that. And that's something we have to look at. So this study table on the right-hand side, your right and my right. In the olden days when we had the PowerPoint projector behind us, it was always switched, but now at least we're looking at the same screen. But we, as part of my PhD, we looked into running related pain postpartum. And this was the final multivariate model of the variables associated with pain postpartum. And we found that delivery type, especially vaginal, any incontinence, but the postnatal accumulated fatigue score of greater than 19, less than 6.84 hours of sleep, if they were novice runners, and if they had a previous running related injury, were all risk factors for increasing running related pain postpartum. And especially being, novice or having fatigue, had those higher odds ratios. And so I want to take a second, because when I do this live and there are lots of people in the audience, they all, the moms always roll their eyes at me because, fatigue and the amount of sleep and all of that is part of the fun of being newly postpartum. And especially if, you're a high level athlete, some of the athletes actually putting some of this out there, but they're not getting enough sleep. They're tired. They're managing motherhood and athletics. But when I'm in the clinic and someone tells me, these things, how I use them is like, okay, so if you have a really hard workout where you're going to now do, a mile for time, but you've had a crappy night of sleep and your fatigue score is really high, maybe we scrap that and we do an easy run instead. And then, let's talk to your coaches about reorganizing the week and doing it on hopefully a better day. And so, really using our sense about load and capacity and seeing like, is this the right time to really stress the body? Or are we putting them in, danger of, something breaking down because things are not optimal? And now with wearable technology too, we can look at that and see, what's my sleep score? Like, how's everything balanced today? And is this the right day to stress the body and the system? Another article that we wrote about getting someone from childbirth to the starting blocks. This is in the Journal of Orthopedic Sports Physical Therapy, JSPT. And this basically talked about, the different phases of recovery that need to happen. So if you look at the first thing on the left, depending on the demands of the sport. So if it's, something like maybe archery where you're standing still, the sport demands are a little bit low. And so you probably spend less time in that first phase, recovery phase, and then the rehab and training. And you can move through those phases pretty, a little bit quicker than something with very high musculoskeletal demand, like maybe gymnastics. And so that, maybe rehabbing a little bit more, making sure that the recovery and training is happening, and then moving into the competition phase. Same with pregnancy-related complications, right? Everyone's pregnancy journey can be very, very different. So it's going to be really important to see like what complications did they have? Were they forceps used in delivery? Did they have a lot of tearing? Was it like 3rd, 4th degree tear? All of that. And so as we're thinking about all of that, all those, if they've had a lot of complications, we may have to take a lot more time in that recovery phase and then slowly returning back. So what is the recovery phase? Really spending the time on making sure that there's wound healing, gynecologically and physiologically, things are recovering. So, basic vitals and not having high blood pressure, which is also seen postpartum, no medical emergencies happening, thinking about, if they've had a C-section, the scar's healing well, they have good body mechanics. And really here, the primary health contact is the physician, making sure that things are moving in the right direction, along with the physical therapist, lactation consultant, mental health specialist, and, anybody else who you think is appropriate to help this athlete out. And then moving into the rehab and training phase. And here's when you're starting to progressively increase load. So progressive aerobic exercises, strength training, sports specific exercises, doing some biomechanical assessments to make sure they're ready for this. And then continuing to support breastfeeding or whatever the athlete chooses, and assessing that mental health component and nutritional counseling and things like that. And here, the primary health contact is that physical therapist with the lactation consultant, the mental health specialist, the coach, the dietitian, of course, the primary, the physician as well. And then moving into the competition phase, here's where they're back to competing. And the most important piece is this arrow, and thinking about when do they need to come back into their rehab training phase and really build up, and then when can they go in the competition phase. So thinking about the continuum of care based on some of these factors, also thinking about very individualized response, because no two people are the same, no two pregnancy postpartum journeys are the same, no two deliveries are the same. So really, and really taking each step at a time and providing that athlete with as much care as you can. And another big thing that people, look at me and say, like, we can't afford to have all these people as part of the healthcare team. Well, how can we, can we get the lactation consultant to, from the hospital help out, like all of these things. So yes, there's a healthcare cost, but, how can we, as we build these programs for postpartum athletes getting back into sport, to have them have the most support and help. So some other factors that was studied affecting return to running. So this study was done by Izzy Moore and her group. There were 881 postpartum women runners, and they looked at different factors that decreased and increased the odds of return to running. And so what they found was vaginal heaviness, which is one of the symptoms of prolapse, fear of movement, which was a unique finding, I think, in this study. A lot of people post injury, like especially with ACL, we hear that fear of movement going back and the chance of re-injury, but we're seeing it also in the postpartum population. And then, things like third degree tears all decrease the odds of women returning to running postpartum. And then when they looked at factors affecting return to running to pre-pregnancy level, they found that fear of movement and vaginal heaviness were also decreasing the odds of returning. So all of these things, thinking about referring them to that pelvic health provider so they can help with the prolapse symptoms and help with, any sort of birth healing, but also help them with that fear of movement by directing them and watching them run and really helping them see that they're on the right path to going back to running. All right. This is a really critical time window where it's a habit formation window. And so it's important that if there are people postpartum women, we want to make sure that they're getting back to sport and exercise in a healthy fashion. And, thinking about that timeline from acute postpartum to late postpartum, really thinking about encouraging them along the way to keep exercising, and then especially if they're elite athlete, helping them realize like when they can start. And so especially if they're elite athletes, we just had a consensus statement published in BJSM, thinking about the different components of return to sport, especially run readiness. And this was one of the questions. It was a Delphi survey. So if you are unfamiliar with that, there a couple of different rounds of the survey, and the people who answer it are experts in the field. So we had a majority of physical therapists, but some physicians, some run coaches answer this questionnaire. And in this article, one of the things we asked is, what is the ideal timeline for run readiness? So I want to make sure that everyone's hearing that it's run readiness, like readiness to try and screen them and start to maybe walk, jog, or even try to do some things. And here, what we found is the majority said cannot return to running at 3 weeks postpartum. So that reached consensus of greater than 75%. But then other than that, there wasn't much debate of 6 or 12 weeks. So 3 weeks seems to be the minimal amount of someone needing to rest before we start some run readiness. And again, really important. It's probably going to be very patient specific. Are they ready for it? Are they healed enough? Is that recovery, piece there where we can start to say, okay, let's start talking about some screening. Are you ready? Can you walk, jog? Are you having any symptoms? Things like that. But really importantly, the biggest thing that reached consensus was the timeline post-birth should be person specific. So looking at the person in front of us, and then any acute birth injury should be completely healed before return to running. And that makes sense from a wound healing standpoint. When we're talking about that timeline to return to run, because that's kind of the question I get in this world a lot, what happens to the pelvic floor or all of that if we return to running too soon. And here was a group that started exercise at 6 weeks postpartum, and those that didn't. And what they saw at 6 weeks and at 12 weeks is that there were really no difference in the groups for vaginal resting pressure or pelvic floor muscle strength or pelvic floor muscle endurance. And same with the symptoms of incontinence or pelvic organ prolapse. There was no difference between the groups if they started exercising at 6 weeks or didn't. And just to clarify, there weren't very many runners in this group, so it was not very high impact exercise. But this is a good positive start, especially in this area where we're learning a little bit more about, how does the pelvic floor respond to things, and maybe exercise early is actually better because it strengthens the muscle and keeps it going as long as they can tolerate it. So it's all a symptom provocation sort of thing at this moment. The one thing that did catch my eye is that the higher BMI were likely to report stress urinary incontinence. And especially if the BMI was over 30, they were 3 times more likely to report stress urinary incontinence. So that is the one thing that they did pull out of this paper. And I think that's important. It also encourages us to keep our postpartum athletes moving and active to help them with the BMIs, postpartum especially. This was the infographic that came along with that article. And so just to point out, the definitions of who, this study was specifically about runners, but postpartum is a runner is someone who self-identifies as a runner, regardless of mileage and frequency. And then, postpartum, we also always get the question of what's the definition of postpartum? And depending on, if you're exercise physiologist or, physical therapist or whatever, you may have different definitions, but this consensus group said, anyone who's had a baby, regardless of the time since birth, should be assessed and looked at. Some key running assessments, some load and impact things came out of this paper, thinking about the biopsychosocial effects. So sleep, any pre-existing conditions, lactation concerns, hydration, fatigue, mental health, all of that. Thinking about support items. Do they need different shoe footwear or bra or, different things to return to sport? And then really educating the runner on the individualized nature of this, and thinking about training and nutrition and hydration. And really importantly, I think thinking about that shared decision making with the athlete and making sure that they are part of that decision making, especially as you work with those high level athletes, helping them. So really, the timeline should be very person specific. And then there was a second companion paper to this that also talked about some return to running pearls. So, training plan design, key muscles to target, how to progress or regress a plan, and some biopsychosocial factors to keep an eye on. I know we're coming close to time, and I have just a couple more slides, but, another big question we get about heavy lifting postpartum, especially during pregnancy and postpartum, and, the pelvic floor. But this survey by Christina Prevalence and her group looked at the impact of heavy resistance training on pregnancy and postpartum outcomes. And in a nutshell, they looked at recreational athletes, CrossFit athletes, weightlifting athletes, and those that maintained their pre-pregnancy training levels until delivery reported significantly less reproductive complications. And so really, the group that did, Valsalva, Olympic lifting, and did it supine, all of the things that, have brought on fear in the past, they said that, didn't alter their outcomes, which is really great that we're doing this kind of research, because there's so much fear in pregnancy and postpartum exercise that, putting out work like this where, outcomes are not changing, outcomes are not worsening, are really, really exciting to me as someone who works in this area specifically. Since we've talked so much about REDs, I just did want to say, if we're asking the questions about menstruation in postpartum women that are lactating, they may not be menstruating, and so thinking about different ways of screening them. And this paper this paper that just came out in BJSM has a nice screening section. So if you haven't seen it yet, please look at it, and it's got some good stuff in there. So really importantly, how do we screen for pelvic health and pelvic floor dysfunction? So really some basic questions is, asking if they experience urine leakage, even just a few drops when they cough, squeeze, cough, sneeze, laugh, or exercise. If they have a bulge or sense of something falling out of the vaginal area or heaviness there. If they experience accidental leakage of feces, experience any pain with bowel movements, tampon use or intercourse, or any bulging in the abdomen. So those are some questions that we can ask to screen. You're a lot busy providers. You can always use the Pelvic Floor Disability Index as well. It's a nice outcome measure, PFDI 20. It asks about pelvic floor distress, colorectal anal distress, and then urinary distress. So that's an easy outcome scale that they can fill out. And then, if there is someone who's having some symptoms and you want to refer them to pelvic floor therapist, they do an internal exam. It's just a digital exam, and they can kind of have an idea if it's a non-contracting pelvic floor, non-relaxing, or a mixture, and usually diagnosed with normal, overactive, or underactive. And they use a different set of scores, power endurance, resting tone, fast contraction, looking at each contraction and the coordination. And usually they may also use a sensor, which is a tampon size sensor. And here is the different scales they use. They use the modified Oxford scale, and they can teach the athletes some NACO counterbracing, which is, think about, are you about to sneeze? Can you contract your pelvic floor right before, and things like that. And then some common errors. The reason why it's probably best to send someone to a trained provider is that when someone's contracting their pelvic floor, they may contract everything. I was doing deadlifts the other day, and I was like, oh, wait, I'm contracting everything, and my poor pelvic floor is tired. So, if someone who would, like me, who has that awareness and is thinking about that, you can just imagine if someone didn't, and what they could be doing. And maybe that's what's led to the dysfunction in the first place, and everything's tight in the pelvic area, and now they're having some groin pain that we need to figure out what is. And so some people will tighten too much and different things like that. And then finally, back to your Doha Agreement paper, what I would add in the not to be missed is also pelvic floor dysfunction, because it definitely could be related to some of the groin pain that the athlete's dealing with. So if you've stayed here this long, congratulations. Hopefully it was exciting and you've learned something, just some take-home messages. Do not overlook the contribution of the pelvic floor, especially when they're having some lower back, sacroiliac, groin pain sort of issues, even lower extremity injuries. It's really important to ask the question, screen for dysfunction, other red flags, refer to your local pelvic health provider or even your MSKPT, who may be able to tease out some of this, and that leaking is not normal. So let's change that narrative. Thank you.
Thank you so much, Dr. Christopher. For those still with us, we are going to try 2 CAQ style questions. So let's see if I can get those launched. So we'll go ahead and start with this first one. Right. Is that coming up on your screen? Okay, yep. Perfect. So our question is, which of the following is the best initial treatment option? Oh, that doesn't seem like the question we planned.
Nope.
Hold tight. Let's see. Let me see
Maybe
if this.
he has several poll questions saved.
Yeah, I
Nope.
think that let's try this one. Okay. Well, we are going to adapt and overcome, and we're going to just go ahead and move on to question and answer. So if anyone has any questions that they want to send in the chat, please feel free to do that. I wanted to get us started by just asking how you would recommend primary care sports physicians to kind of educate our patients that we're referring to pelvic health or
Mhm.
pelvic health providers and pelvic floor PT about kind of what to expect for the initial appointment and subsequent appointments and when they should generally start to feel some degree of benefit.
Awesome question. Yeah. So the first thing is, how do we prepare for what's to come, right? So it's very different from your regular OB appointment or your, gyne appointment every year. They just use a digital exam. And so usually pelvic health providers will have a very private space. They'll robe you just like you would you don't have to disrobe from the top, just bottom down, and then you have sheets and things like that, and then it's a gloved digital palpation where the provider will ask you to squeeze, contract, do different things, and then get a sense for the pelvic floor. So very much less invasive, and sometimes the first session they may not even do the internal exam, just based on the comfort of the athlete in front, and just kind of getting a sense of what they're doing. And a lot of times, can even do it external palpation as long as the athlete's comfortable with it, and get a sense to get started. So the biggest probably take home is, don't be nervous. It's not invasive, and the pelvic health provider will work with you to make sure you're comfortable. And especially athletes who've had trauma, the pelvic health provider can work with them on techniques and tips, and make sure that they're ready for the internal exam if needed. What was the rest of your question? Sorry.
Is there a typical kind of duration or number of sessions
Mm.
that you would expect the athlete to start to get some sort of response?
Yeah, so I think that's a hard question, right? Like, it's probably like any other injury. Sometimes the hamstring strain, you can feel better quicker. Sometimes it takes a little bit longer. So I think just like any musculoskeletal injury, maybe asking them, have you been to PT before? What was your experience? This is a muscle as well. And so, sometimes I've had people have immediate relief because finally someone has identified the cause of, the symptoms, just having someone relax or giving them a wand to do some, soft tissue work, things like that. Sometimes it takes a while for that person to relax. I mean, I think, when this is a live session, I make it really nice and awkward. I make everyone do the relaxation and do the contraction with me. And a lot of us realize, like, oh, that's where I hold on my stress. My pelvic floor is always contracting. So, over time, is that something that's causing the issue? So I think it's one of those that we just have to, do more, and do some exercises and see where we are and how to improve. But really, if there's no improvement, in 4 to 6 sessions, if that's something that they may send you to Urogyne because it's more complicated, or it may send you back because it's not pelvic floor related, or things like that.
Wonderful. Thank you.
Yeah, no
Another
problem.
question was with specific to postpartum athletes, so right up your alley. Do you find that pelvic floor dysfunction and diastasis recti kind of often coexist or play off one another? And do you have any recommendations for those athletes?
Yeah, so let's kind of so you asked about them together. So let's start with that. So interrecti distance and separation of that is is a normal thing. If you look at the anatomy of the linea alba, it's almost like it's designed to part, right? And over time, again, there's a lot of fear over the interrecti distance, and only once the interrecti distance is very wide, I think it's like 4 finger breadths, if you're using that measure, does it become a diastasis recti. So, really thinking of like the words we're using for that. But some separation is absolutely normal as part of the pregnancy journey. And then in the past, we've been afraid of it because we've thought that it contributes a lot to dysfunction. But what we're learning is, it's just like a muscle. So no, I have not seen it like directly related. But they could have both increased intererecti distance and they could have pelvic floor dysfunction, or they could have one or the other. So again, really important to evaluate on the athlete and see what's happening there and what we can do about it. But not fear mongering, because that's unfortunately the state we are in. Like everyone's so afraid to move because, you know, we went to the other side of the spectrum about like identifying these things, but now we're realizing that some of this is normal part of the process. And, you know, but what's not normal is leaking. And so like, you know, any other muscle, like let's get it evaluated and see what's going on so you can have some success. And some athletes may choose to continue to do their sport while they're doing their rehab, right? And, you know, wear a pad or do different things. So it can happen in conjunction. It doesn't have to be, okay, now you're sidelined for, you know, so many days while you're doing this rehab. It's kind of, it can be worked together as long as the athlete can tolerate it and it's not making symptoms worse.
Yeah, I think one of my favorite takeaways was kind of like you said, some of that early, that beginning evidence of heavy lifting not necessarily resulting in worse pelvic floor dysfunction, and just encouraging our pregnant athletes that they can continue within the safe boundaries of their pregnancy to
Right.
exercise, because all of the big impact that has on the pregnant mom's health, the baby's health, everything kind of going forward. Um, on that same kind of note, an additional question was about, you mentioned kind of the assessment of readiness to run. And
Mm-hmm.
obviously, for the pelvic floor physical therapist, that's something that you guys probably assess often. But what advice or guidance might you have for the primary care sportsman physician to kind of try to assess that readiness to run for our athletes?
Yeah, that's a great question. And that could be a talk on itself. So if you want, you know, if you want to do that, please do reach out. But yeah, so I think there are different components, right? So there's that physiologic recovery, it's the wound healing, all of that. So are they good from a medical standpoint? Are the vitals normal? All of that. You know, sometimes, you know, has the bleeding stopped? Has the lochia stopped? You know, all of those things are really important pieces before we can start to bring in the sport piece. And then usually, you know, strength, flexibility, and that's typically what, as a physical therapist, someone comes in, right? We'll look at their like resting strength and flexibility and all of that, and then looking at their biomechanics for the sport. Um, so there are some resources out there, and this paper will kind of highlight some of those. So please do go look at it. But you know, thinking about the biopsychosocial things that we talked about, are they getting enough sleep? Are they getting enough hydration? Are they eating enough? Because in this population, that relative energy deficiency syndrome, like we want to keep an eye on it. And again, you know, they're trying to lose weight because that's not the body that they have as an athlete, right? But are they doing it in a healthy way and not just, you know, not eating enough and things like that. So you I didn't really answer your question, but I think the things you can do is make sure medically they're, you know, they're at the stage where they can begin to return to sport. Nothing's getting worse from a pain symptom standpoint. Um, you know, maybe having, you know, if you have the ability to watch them do their sport or some movements and mechanics, looking at that. But really, sometimes, you know, just letting, if the basics look good, just letting them start to slowly, you know, reintegrate into it. You know, go do a, you know, a warm up. How does your body feel? Did you have any symptoms of pain? Did you have any symptoms of pelvic, you know, any pelvic health symptoms? Okay, you didn't. Great. So now, like, slowly, let's increase that. What would be the next step? And, you know, especially high level athlete, they will know how to, you know, slowly add in things. It's actually the people like me, the recreational athletes who are like, I can do everything. Let's, like, you know, let's go from running 1 mile to 5 miles. That's the problem. And so thinking about just I think the biggest thing is like the education of the step-by-step piece, you know, thinking about the load, thinking about the recovery piece and adding it all together. So hopefully that's a little bit helpful.
No, I think that's perfect. I mean, again, thinking of, like you said, all of those things that may play a role, and then tying it back to the things that were associated with the kind of pain and increased pelvic floor dysfunction, and making sure that those risk factors aren't present from the beginning. I
Yeah.
think that's great. Well, seeing that we are running out of time, I wanted to just turn it over to you to see if you had any final words of wisdom for us before we sign off for the night. And just again, thank you so much for all the education you shared.
Yeah, no final words of wisdom, but I'm always available for any calls. So if you run into, something, wait, you have a question, please do email. It's schristopher12 at tufts.edu. And you can probably find me at the Tufts DPT website. And it's a very exciting time because a lot of people are fed up of not enough research in this field. So stay tuned to all the amazing work that my colleagues out there are doing to encourage movement and sport in this population. Finally, yay.
Wonderful. Thank you so much.
Thank you so much for having me. Have a nice night.
You too.